Namaskar, I am Dr. Anil Sawaria coming from the Ajmer to attend my conference APICON 2022. It is a great pleasure to attend this conference. I am also thankful to Dr. Puneet Saxena sir, Dr. K.K. Parikh sir and Dr. Shyam Sundar sir to invite me as a faculty to deliver a lecture on diabetes ketoacidosis. Diabetes ketoacidosis is a complication of diabetes of the acute decompensation condition leads to hyperglycemia, hyperketonemia and ketosis, and ketonuria leads to dehydration of the body, leads to water deficit, electrolyte imbalance and also leads to various complications like the altered sensorium and death. So, DK is the acute hyperglycemic complications of the diabetes. It should be dealt with carefully whenever you encounter this kind of patients in the casualty and your day-to-day practice. And I also highlighted that DK is a very common in the type 1 diabetes and also seen in the type 2 diabetic patient. When we seen these patients are neglected or treatment avoidance by the patients or inadequately treated type 2 diabetic patients. Diabetes ketoacidosis clinically presented with hyperglycemic clinical features like polyuria, polydipsia, polyphagia, or due to hyperketonemic feature leads to metabolic acidosis and clinical features like pain abdomen, nausea, vomiting, and also the clinical feature of like this signs of dehydration like drowsiness, feeling giddiness, and also there are features of dehydration like the dehydrated skin, dry skin, the shrunken eyes, tachycardia, hypotension is there. All the clinical features are presented in diabetic ketoacidosis. So, you should be aware of all these clinical features and sign. There is a characteristic fruity odor coming from the body of the patient. This is a fruity odor of the acetone. The nail paint remover smell is coming out of the patients. This is a clinical feature of diabetic ketoacidosis. How we can diagnose it? We can diagnose by patient blood sugar level is more than 250 milligram per deciliter, and patient is also diagnosed with the ketone body diagnosis in the urine. There is a ketonuria to detected by heuristics give the color brown color, dark brown color and the level of the round, but it is not useful to diagnose subclinical diabetic ketoacidosis or mild diabetic ketoacidosis because beta hydroxybutyrate is not diagnosed by the nitroprusside test. So, the point of care tests are available by the devices very beautifully designed nowadays to detect blood ketonemia early stage we can deal with, and these patients are all giving the severely dehydrated to manage with the IV fluids. The treatment of choice to manage the dehydration, manage the hyperglycemia, manage the electrolyte imbalance, and all this should be corrected as soon as possible when you see the patients in your day-to-day clinic in the casualty. Most of the patients encounter in the casualty patients. So, these patients needs hydration. Give the correctors IV fluid is a normal saline because most of the patients are in hypotension. The IV fluid like normal saline 0.9 NaCl fluid is sufficient. In the initial stage we replace the fluid fast as soon as possible. We give the fast. 2 large bore cannula should be put initial stage or central line is better. Give the IV fluid is ideal fluid is normal saline. In the first half an hour give the 1 liter of fluid, the next half is another 1 liter, and then just the hydration status of the patient. If need more fluid, they go for next 1 liter of fluid in the next hour. Repeatedly we have checked the electrolytes, blood sugar level, hydration status of the patient. If patient is hydrated well, we shift the fluid normal saline to half saline. Then we need to treat the hyperglycemia with giving the insulin in the dose of 0.1 unit per kilogram per hour infusion with a bolus dose of 0.15 unit per kilogram per hour as a bolus, and we watch the blood sugar level fall by the 50 to 70 milligram every hourly If it is not achieved, we give the another bolus dose or just double the infusion rate to keep the fall in blood glucose level 50 to 70. If it is achieved, then whenever we feel that the blood sugar level reaches to the 250 milligram per deciliter, we switch over to the half saline and plus a 5% or 10% dextrose with this IV fluid solutions, or continue watch the every 2 hourly blood sugar level, also the electrolyte check every 2 hourly. Now potassium replacement is also required in this condition, because total body potassium is deficit in diabetic ketoacidosis. Whenever we check the diagnostic lab, potassium level are normal, low or higher side. But if it is low or normal, then we start the insulin therapy. If it is lower than 3.3 millimole per liter, then first we transfuse the KCl into the form of the KCl and 1/3 in the form of potassium phosphate. So phosphate replacement is not required, but KCl should be given in the each and every liter of fluid. So we can keep the blood serum potassium level between 3.3 to 5 millimole per liter. So we can prevent the cardiac arrhythmias and any other complications of the hyperkalemia or hypokalemia. Now we come to the bicarbonate therapy. Patient of DK are always in ketoacidosis, but this acidosis is revert. Whenever we are giving to the fluid therapy with the normal saline insulin level, this correct with this therapy also, or no need of bicarbonate therapy. Only bicarbonate therapy is required when pH is lesser than 6.9, and we give the bicarbonate therapy when the required every 2 hourly transfuse the bicarbonate, and we keep the close watch on the venous pH. No arterial ABG is required in the DK patient. Venous pH monitoring is suffice. If we keep the pH more than 7, patient will be already hydrated. Insulin therapy leads to normal level of acidosis. So this is the main treatment strategy: is replacement of fluid, replacement of electrolytes, keep the blood sugar level normal, so the patient become hydrate, normal euglycemia, and correction of the electrolyte. This all correct the DK, and patient we can save. Most of the time whenever we are going to the therapy, we face lots of complications like altered sensorium, coma, seizure, rhabdomyolysis, and various ARDS, cardiac failure. When give the lots of fluid and not monitored, patient went into the cardiac failure, ARDS. So we should keep on watch on the complications also. Thank you.